Well, thank you, Father Fitzgerald, for a couple of things, not for ending early, by the way. Yeah, we've threatened our speakers that we're very tight on time, and they have to really keep everything tight. And unfortunately, Father Fitzgerald listened to us. That's terrible. But thank you, Kevin. You know, it's been said if we're to preserve civilization, we must make certain of its benefits available to many, not just reserved for the few. The development of curative treatment for children with cancer is a benchmark for medical progress, and the life-saving therapies really should not be sequestered within the borders of a few countries. So how do we bring cell therapies to the developing world? Where do we even begin? Let's see how one boy's illness, a supportive special family, and an incredible doctor are bringing cures to the children of Rwanda. Memorial Sloan Kettering Cancer Center, one of the preeminent cancer research and treatment institutions in the world. Kigali, capital of Rwanda, one of the smallest countries in Africa, with a mostly agricultural economy about half the size of Vermont's. While Rwanda has made great strides in healthcare in recent years, treatment for serious diseases like cancer still lag far behind, especially for children.
What I would like to see is that each person has the ability to have the same opportunity for cure. Whether you're in a country with limited resources or you're in a country that has unlimited resources, it should be the same for our future children. It is only right and it's only fitting.
Dr. Tanya Trippett is a pediatric oncologist at Memorial Sloan Kettering who wants to help eliminate that disparity in cancer care for children. So Dr. Trippett has put together a foundation to build a regional children's cancer hospital in Kigali. But to understand how Dr. Trippett came to be involved with such an ambitious plan, and Rwanda in the first place, you have to go back about 5 years.
All I heard is cancer. As soon as she said you have cancer, and then she said you have cancer, lymphoma, I didn't really pay attention to what it was. I just was in shock.
At age 13, Eugene Gasana Jr. had been diagnosed with early-stage Hodgkin's disease, a type of often curable lymphoma. It was chance, or perhaps fate, that Eugene Jr. was referred to Dr. Trippett. Eugene goes by Jr. because his father is also Eugene Gasana, the permanent representative to the United Nations for the Republic of Rwanda. He remembers vividly the family's first visit with Dr. Trippett.
She looked at Junior and said, you know, you have cancer. I was really shocked, devastated. Oh, please, what are you saying? But I will make sure that I will fix it and you will be healthy. I cure it.
It took 12 weeks of chemotherapy and nearly 3 weeks of radiation, but Junior has been cancer-free for nearly 5 years.
You're basically attempting to prevent resistance from occurring, which is the #1 cause of cancer returning and also from persons dying of their cancer.
So during Junior's treatment, Dr. Trippett became a friend of the ambassador's family. That's how the adults came up with the idea for the cancer hospital in Rwanda. Actually, the real idea, the inspiration, came from Junior.
The kids in Rwanda, they don't have the same facilities or same type of treatments we have here in America. So the idea of trying to help them out in any way possible was my main purpose at the time. Because in Rwanda, you do have to travel pretty far to get your treatment, and some kids don't always eat food, or the parents don't always eat food because they have to get their kids the food.
Here's how the idea started. Shortly after Junior completed his therapy, the Starlight Foundation wanted to grant him a wish, but there wasn't anything Junior really wanted.
I know that my parents, if I asked them, they could probably get me anything I want. I didn't really care if they could get, if I could meet a celebrity, then these celebrities are very busy people. They won't remember me, so there's no point in meeting somebody that I'll remember for the rest of my life, but they won't remember me.
The only thing Junior could think of was to ask for a Harley Davidson for his father's driver, a big motorcycle buff. When that was turned down, the idea of a hospital started to take shape. So the family and Dr. Trippett formed the Eugene Gasana Jr. Foundation to raise funds for the hospital. And they enlisted a number of professionals, including noted architect David Adjaye, to donate their skills through the concept of intellectual philanthropy. It's their way of giving forward a debt they know they can never repay.
I don't know how you pay that back. So it's easier to pay forward or give forward to people who don't have the same treatment, so they can also be inspired to give more and just spread inspiration to the whole world.
I think it's no longer about Rwanda. It's about the humanity. It's about the people who are suffering, all those kids. And the beauty in this is that, helping those children, they are the future, which reflect to this pay forward what Junior was wanted it, to invest into the future, that we wouldn't wish other parents be in that case like us, helpless, seeing that they cannot help their kids.
What I would like to see is a leveling of the playing field in cancer. Cancer shows no barriers or boundaries. And this is our way of giving forward and standing in solidarity with the world's children to say, you should have this opportunity. We want to make it available to you.
Ladies and gentlemen, please welcome Dr. Tanya Trippett, pediatric oncologist for Memorial Sloan Kettering Cancer Center, and Dr. Raphaël Rousseau, Group Medical Director and Global Head of Pediatric Oncology from Genentech, Inc. So, Dr. Trippett, let me start out with you here. I think it seems obvious, but we need to identify the specific elements, the challenges and obstacles to bringing better, if not world-class, cancer care to children in undeveloped or underdeveloped countries. What are some of those challenges or roadblocks that you've identified?
I think the first roadblock is certainly the issues of cure. In the United States and in developed countries, 80% of children are cured of their cancer. In developing countries such as Rwanda, the cure rate is 5%. So you have a staggering statistic that you're trying to overcome at the same time. And the reason is largely because of lack of resources and also medical training. Obviously, when you look at a country the size of Rwanda, there's one MRI in the country. There are 5 CT scanners. In New York, we have over 100 MRIs and hundreds of CT scanners. So the disease is advanced at the time of start because of a lack of diagnostics. Another large burden is the absence of chemotherapy. In our country, we can write the prescription, or in order for chemotherapy, we don't think about a limitation in access. In Rwanda, you may start one cycle of treatment and there's no further therapy. So if you can imagine a mother or a father walking 2 weeks to get curative therapy, only to find that they have the diagnosis of cancer, but not enough chemotherapy. So the chance of cure is marginalized significantly. There are no subspecialists. There's one pediatric oncologist who actually just finished training in South Africa. And is moving forward to help with the initiative in the country to build an oncology program in the country. I have to applaud the pediatricians who are actually the oncologists, who have learned very quickly how to treat cancer in the country and are very, very committed. And then there are issues of infrastructure for infection control, the quality of the equipment for diagnostics that results in delays in treatment. Also, more importantly, you have a mobile population. So it's hard to maintain follow-up when the family lives 2 hours away and they have limited resources to travel. So it's hard to deliver healthcare effectively. And these are all challenges, but I don't think that they're insurmountable.
Well, we're going to get into that and how we do that, and there are a couple of questions that I have as follow-up to that. But let me ask Dr. Rousseau, because Dr. Trippett mentioned in a couple of circumstances, for example, lack of medications, chemotherapy, and so forth. What, if any, responsibilities do drug companies have in helping to deliver adequate care in these countries?
Yeah, so the issue of access to care in those countries is something that the industry, I think, is taking very seriously now. And a number of companies are proposing access programs that allow to deliver those drugs in those countries at a cost that is adapted to the buying power of those countries. So that's one effort. The second one that I see as a pediatric oncologist is whereas we have a high cure rate of children with cancer in the Western world, there is still a huge gap in emerging countries for children with cancer. When we see now that Burkitt lymphoma is curable at a rate of more than 90% in the Western world, it's still at 50% in countries like Uganda. So access to care there is critically important, and for companies to set up clinical trials under good clinical practices, I think will make a huge difference, raising the standard of care, raising the level of research capabilities, training physicians over there, and bringing those innovative drugs not only to Western children, but also to children in emerging countries is critical.
But you mentioned clinical trials, and we've all heard some of the, for lack of a better term, horror stories of patients who are enrolled in clinical trials. They get through a clinical trial, the trial ends, and now they're out of luck. So how do we move beyond a clinical trial to something a little more sustainable?
Yes, and that's a very important point. Ethically speaking, it's absolutely not acceptable to start a clinical trial if there is no prospect to make the drug available commercially or even for free. And so many companies, including ours now, are making sure that before starting a clinical trial, there is a strategy to make the drug available, either through access programs and share cost sharing with the governments there, or by giving free access to the drug. So it's an ethical challenge for many companies, but I think it's the right thing to do.
So Dr. Trippett, a lot of this sounds like it comes back to dollars, or whatever the local currency is. How do we overcome that? I mean, MRIs are expensive, CT scans are expensive, medications are expensive, even if we're able to get them at reduced rates or for free from drug companies. How do we overcome that?
I think that there are challenges economically, but I don't think they're insurmountable. I think the type of sessions that we have today, in which we brought persons from corporations, from governmental agencies, parents and friends of persons who have had experience with a personal experience with cancer, I think if we all align as a cooperative community, that will make the difference. Also, we have looked at a concept of intellectual philanthropy. When persons are dealing with the staggering statistics such as this, most persons would think that it's too big of a problem or a challenge to take on. What we have said is, let's leverage our expertise that we utilize every day in our workspace and our alliances, and charitably extend the offer of our expertise and our resources to other countries. And that's what we're working on at this time.
So intellectual philanthropy here is this is not money, these are not dollars, this is giving of your expertise and knowledge, doing it that way.
There is expertise and knowledge is one part, but hand in hand you have alliances that are economic. Corporations have access to the ability to give shared equipment to countries much like Rwanda. If you look at the IAEA, there is an accord and there are grants that are in place for developing nations to bring nuclear technology, particularly diagnostic imaging, into developing countries. So there are grants that are available. Certainly there's support through the United Nations. There are a host of avenues in which your alliances actually can leverage those resources that we don't even realize that they're readily available to us. And so obviously, we think that this is going to be a challenge that's going to require networking. It's going to require partnering. And then also having a foundation, much like we have, of looking at charitable resources in supporting these types of initiatives. I think that
So
would
there
be
often
important.
are resources there, we
Yes.
just don't know,
But they just have not been tapped into.
or they don't know where to look or
That's
how
right, that's
to
right.
get them. Dr. Rousseau, let's go back to the clinical trials question. We know that clinical trials help contribute to terrific cure rates in developed countries. How do you get children in underdeveloped countries, enable them to participate? And are there governmental issues for, say, Genentech to come in and run a clinical trial in countries?
So
Particularly with kids, which is often a different person or a different population obstacles. That's the word I'm looking for.
yeah, children are not little adults.
Exactly.
That's what we say. So the key word, I think, is collaboration. And it's a partnership between our academic colleagues at the Sloan Kettering, for instance, but we have colleagues also at the Fred Hutchinson in Seattle that have initiatives reaching out to our medical colleagues in those countries. For example, we're setting up a new trial testing a very innovative drug, a monoclonal antibody targeting lymphoma cells in Uganda. Uganda has 500 new cases of Burkitt lymphoma per year. That's the same number of cases as in the United States for a much smaller country. Only 140 of those children will eventually get to the clinic, diagnosed and eventually treated, and less than 50% of them are cured. So the idea is to team up with a group of academics here in the United States, work with them to establish such a clinical trial under the same rigorous rules as what we're doing in the Western world, with our African colleagues and running a clinical trial of the same quality that what we're doing in the Western world. And with this, deliver results that hopefully will compare to the survival rates that we're seeing in the Western world. And that's a win-win situation because the data that is obtained through those rigorous clinical trials will help inform the conduct, the design and the conduct of clinical trials in the Western world. So I think by protecting children through research rather than from research, and moving away from the idea that there are too many obstacles to run clinical trials in emerging countries, I think we'll raise the standard of care, we'll raise the survival rate for those children. Now, there are some obstacles that we're not seeing in the Western world. The chain of cold, for instance, making sure that our drugs are not staying on a tarmac under the sun, making sure that the drugs are not stolen and used in another way, making sure that the children can be maintained under surveillance either at the hospital or their local care, adapting to the healthcare system over there where the parents are very much involved, where they may have to go back to their village. How do you follow up with those patients and making sure that you acquire the safety, the efficacy data back? So there are a number of challenges, but as Dr. Trippett said, I think we can overcome those challenges and again, raise the standard of care and make sure that the chances that we're given to children in the Western world are shared with kids in emerging countries.
Some of those challenges sound like they will require, however, governmental cooperation. Are the governments cooperating sufficiently to allow these trials to happen?
So yes, they are when there is actually in those countries an entity that's capable of dealing with pediatric diseases, and that's not always the case. So one aspect of collaboration is working with charities who have a tremendous knowledge in working in those countries. I'm thinking about the Bill Gates Foundation, for instance, and it's not an issue for us as an industry of funding. It's more an issue of expertise from those charities which have worked for many years in other disease areas, generally infectious disease and vaccines, but to gain their knowledge alongside our academic colleagues to make sure that we're not reinventing the wheel. So when there is a gap with support from governments, we can close this gap by working with philanthropic organizations which have vested knowledge in those countries.
But it sounds like what the real enabler, at least initially, is this collaboration with people like Dr. Trippett or other pediatric oncologists. They make the initial introduction, if you will, rather than the drug company, and then you assist.
Correct, but again, I think with many of us now moving into industry to be advocates inside the industry for the cause of children, I think it's a natural collaboration that takes place, and so there are many collaboration now in the Western world between industry and industry researchers, pediatricians with our academic colleagues. So it's only natural that we now start thinking about moving out of the Western countries and do what's right in emerging countries.
So Dr. Trippett, well, they need you, so don't forget that. The next time you need something, go back to him. Tell me now about, we touched briefly just in the video, this extraordinary collaboration that you have fostered to build a regional cancer hospital for children in Kigali. Tell me about that, and are there any other examples? Do you have any role models?
Sure. Let's talk about the role models first. In Rwanda itself, the Clinton Global Initiative has a huge presence, and also the HRH program, which actually brings healthcare professionals into the country to assist with training, obviously has had a huge impact on the country, as well as Partners in Health. There's an oncology facility in the northern part of Rwanda. What we're looking at is an additional wider bridging concept of care. First of all, having experts within an academic center working side by side to custom and fit the hospital according to the functionality of day-to-day practice of oncologists, of radiation therapists, of surgeons that work in comprehensive cancer centers. Luckily, my colleagues at Memorial Sloan Kettering have united with me in this initiative and are providing expertise in each sector of the hospital. In addition, we've had the advantage of collaborating with David Adjaye and his team, the architect. And David's focus is building buildings that change society, that they impact the community in which the building resides. And so we've been very, very fortunate to have a close collaboration with David, and he's brought with that collaboration a network of corporate sponsors that are helping us at this point. So Arab out of Johannesburg in South Africa will be helping us with mechanical engineering and plumbing with the hospital, with ACOM with project management, BTKM who are quantity surveyors, which will keep us compliant with our building practices and codes. Also, we have a landscape architect who is Martha Schwartz out of London, England, who will bring in the concept of beauty in the environment. We do know that with patients who are tremendously ill, that beauty and the ability to interact with their community helps them in their recovery phase. And then in the New York sector, we've been very fortunate to have Jeffrey Berman Architecture, who has joined us as a hospital specialist, and their specialty is actually building high-level cancer centers. And he's extended that work philanthropically to us throughout Rwanda, and we hope this will be the first model of its type. So we've developed a network partnership with each of those corporations, as well as the medical community.
This also has to be culturally sensitive. You're talking about setting it up for oncologists, surgeons, radiologists, and so forth, but it also has to fit in to the way the people of that country.
Yes. There needs to be an insight to have an engagement with the country in which you're working. We believe very, very strongly in reciprocity, which is an exchange of culture and ideas and respect of that culture. And so we've been very, very fortunate to leverage David's global perspective of working in Africa as well as other nations to begin to develop a hospital that is culturally conscious and one that will fit nicely within the community of Rwanda. So we've been very fortunate by the choice of the architect that we've chosen. Luckily, the corporations also are global corporations, so that's really helped us to begin to look at marrying the culture with the actual building.
Terrific. So, Dr. Rousseau, you mentioned philanthropists or philanthropic organizations. What role can they play in really facilitating this? And under that umbrella, would you include NGOs as having a role or not?
I think, again, here collaboration is key, and whoever is willing to help is welcome, especially if they come with experience in working with those countries to better understand the cultural environment, the financial environment, the healthcare system. So this is where NGOs can be critical in setting up those clinical trials because the clinical trial does not end at the door of the hospital. The follow-up, especially for anti-cancer medicine, can require several months or years. So they know better than us how to reach out to those patients once they're back in their homes and villages. So that's one aspect. The other one is financial, because the company will take care of setting up the clinical trial, but the infrastructure, we were talking about equipments, all of this costs a lot of money. Those countries may not have that capability. So here, philanthropic money can be useful, and training the physicians. So we have programs in industry as well as in academia in bringing in or training on-site nurses and physicians on how to deal with central lines, chemotherapy, and their side effects. So all of this requires funding that industry is providing in part, but again, this is a collaboration, and this is where philanthropic organizations, NGOs, can really help.
Talk a little bit more about the follow-up that you were mentioning there, because in a clinical trial, the data has to be good in order for you to know whether or not the medication or whatever it is that you're doing is actually doing that. So that follow-up in this case is really all the much more important when it comes to things like a clinical trial.
Exactly, and so this is where we have a huge, not only scientific, but also ethical challenge, because you don't want to expose children to drugs that could be potentially toxic, especially those new drugs, immune checkpoint inhibitors. I'm not sure we'll be able to test them soon in those countries, but that's going to be a challenge because the response are known to be delayed. So we're starting with drugs that we know much better, that have been used in the Western world for a number of years, and that we know the safety profile, and so we know how to monitor them. And so we'll start little, rather than starting to be too ambitious, and starting with pilot studies. I was mentioning the one in Uganda, where we know that we have the capability, the network, to be able to follow those patients. And if that works well, then we'll be able to expand our outreach and making sure that we can do the right thing for those patients on a clinical trial.
And I imagine then the word gets out that this is okay and the follow-up is okay, and you can expand as that knowledge gets out into the communities.
Exactly. That's somehow an experiment with
trust.
And trust. Yes.
Yeah. So, Dr. Rousseau mentioned something that I think is important that we sometimes miss as well. This is more than just about getting more drugs and more scanners and whatever. We need physicians there, and we need preferably local physicians. How do we train them and then get them to stay?
I think, first of all, you need a bridging organization or a group of alliance of physicians who are willing to share their knowledge in a way that's concerted, that's organized, and is a commitment over time. And so what we have begun to look at is ways in which we can use telecommunications for training for physicians that live long distances away. This is one way to bridge that educational gap. Another is to foster granting programs that allow physicians to train side by side in the United States, with the understanding that obviously we're training with the intent that that physician will return or nurse will return to their country. And then also with a hospital such as what we are planning to build, we believe that this will allow us to have retention of visiting physicians and professionals, that they will have the tools with which to be successful in their intervention. And the plan is to do this on multiple scopes and levels, to do this from the nursing perspective, from the physician's perspective, even down to the housekeepers that are taking care of the hospitals. As we've worked with our architects, one of the issues that is an issue that we weren't quite familiar with is to sustain a high level and high performance hospital and to keep the infrastructure intact. The actual persons that are in the custodial department have to know how to maintain the infrastructure of the hospital. So it will be a multi-level training program that we will actually look at that will be comprehensive. in addition to the high-level expertise. But I think that the best and most sustainable model is to utilize the facility that we're building as the bridging point or the union point of education. So one major tenet for us is medical education, and it's a commitment that we have sustained a lot of effort to be able to do so.
Terrific, terrific. So whenever I do these, I like to have you give us a parting thought. Give me about a minute, no more than a minute. What do you want this very high-level group here to take away? What's the take-home lesson that you think is important that you want them to take away from this?
You're
next.
As a former academic, very frustrated about not getting drugs, medications soon enough for children with cancer. We're now seeing a change by people moving in the different areas of that network, industry in particular. And so leading by example, I think is very important. So I'd like to see more companies involved in pediatric drug development, especially in cancer. And with this in mind, working with our academic colleagues to expand outside of the Western world, because there are still a lot of things to do for children with cancer in the Western world, but the priority is clearly with children in emerging countries where cancer is prominent and still very lethal.
And is there a role for Genentech, for example, to bring in perhaps your competitors and say, come work with us in these areas?
So to me, this is not an area of competition. There is no market, which is, the dirty word is money here. And clearly in pediatrics, this is not the case. So we're all in for a good cause. And I think industry needs to put its money, its resources at good use here. And so leading by example, and that's what we're doing here in the Western world by leading those clinical trials that are innovative and that allow for multiple companies to work together in a pre-competitive way, I think is really the future of pediatric drug development in oncology and maybe other disease areas as well.
Good. Well, we have some other drug companies that are here later on in this in the conference. I'm going to hit them up with the same question. Final thoughts. What do you want people to take away?
I think what I'd like for everyone to take away is the initial inception of why this foundation was formed for us, which is what Eugene Gasana Jr., who's here today, said to me, was that he wanted for the children in Rwanda to have the same chance of cure as himself. So there needs to be a selflessness and a value of every human life, whether it's in the person is in the United States, whether they're in Rwanda, whether they're in Chile, that each life is important. And I think that it is our responsibility as physicians to set the example of leveraging our contacts, our intellect, our resources to help in countries in which the chance of cure is very, very small. I think by bridging that gap, we give a hand up to those children that need us the most as their true advocate.
Couldn't have said it better myself. Thank you, Dr. Trippett. Thank you, Dr. Rousseau. I hope that people will listen, and we will, in fact, move these therapies into the developing world. Thank you very much.
Thank you.